after the drain is put in, you will need a transducer. Only thing you will need out of this part is the actual transducer, so you will tear it down. And that's all you'll need out of that. And you'll get a flush, get up to that end, pull out, get all the air out. If they've just put the drain in, keep it close off to the patient so that you can get an opening pressure. Pick it up to the side like that. To change your label on your monitor to ICP. Zero it just by turning it off like that. It's kind of like an arc line sideways. And then you hit zero calc, it won't have a zero all on there. And to get an ICP, it will be hooked up. To him, and you will open it. To get an ICP, I'll show you the level and zero after this. You will open it up to him. So off to the drain, open to the brain is a good way to remember how to get an ICP. Usually with Ventrix, you don't continuously measure unless you're doing a trial to see if it come out. So you just check it every hour. After that, just turn it off so that it's open to drain to the patient. And you can leave it off like that. Nothing will happen. And then just recheck, or off to the drain, open to the brain, and then so it's always ask your surgeon if they want water or millimeters of mercury. So when you first put your drain in, what you're going to do is, we'll pretend my patient here is up a little bit higher. But what we'll do is immediately clamp off to him. You want to drop your drain to zero. I'm just going to hook it up like this for demonstration purposes. If you don't have a ruler, you can use this right here because it's pretty flexible. Always do a zero reference, and you're going to level it to their tragus or their external auditory canal, or EAC. And you can use as a good, if you don't have a laser or a ruler, you can just use that to balance it. Of course, every time you reposition the patient or elevate their head of bed, you have to re-zero it out. After that, before I open it up, we'll say that they want it at 13 of mercury. Make sure it's level to him, stays like that, then I will open it up to drain. And a good way to assess it is you will see, usually with a good patent drain, you will see fluctuations in their pulsation. It'll tidal in here. And that's how you can, if you have any issues with, if you're questioning your drain's patency, just drop it down to zero and see if it's patent, and it'll usually drip. Sometimes patients that have been draining for a while, sometimes they won't if they don't have any, they have a lot of cerebral edema, they won't drip too much, but you always should have that kind of tiling that'll show a patent drain. If I'm going to take him to CT, what I will do is turn it off to him. I can clamp off here. I always have two spots. Make sure you empty this out every hour, and then before you go empty it, because if anything gets up in that uretrol, it won't drain when you get back. Then I'll just lay it on him, disconnect. When I come back, I'll just repeat everything again. Level it out, zero him. Always put a sign on your bed that instructs people not to touch this, reposition without you present in the room. If you notice your patient starting to cough or anything like that, you need to clamp it off to him, because when you cough, you increase your ICP and you will overdrain your patient. If you do overdrain your patient, that happens, just clamp them off, let them reaccumulate, and then just keep a close watch on their ICP and neuro status. Usually if they're awake and alert and can talk, they'll complain of a headache, or they will become altered, they'll become a little drowsy, lethargic, but usually that kind of resolves, but just that's why you have to keep a close eye on them not to overdrain them. And when you get back, always make sure you're open.